Hey everyone, welcome to my Day in the Life series here on White Coats and Corgis. Most of you probably know me from Instagram or TikTok, where I make helpful free content for pre-meds and talk about my journey as a first-generation medical student. My mission here on YouTube is to give pre-med students all the information they need for a career in medicine. So in order to do that, I've teamed up with MedSchoolCoach to create this series where I'm going to do a deep dive on each medical specialty. And I want to start off by saying that it can be really difficult to accumulate the number of shadowing hours you really need to be accepted into medical school. And especially nowadays, this can be really challenging. A lot of physicians aren't open to shadowing opportunities in person the way that they were before. So that is why MedSchoolCoach decided to collaborate with over 20 doctors to give you a behind-the-scenes look at practically every specialty that you might be interested in. And this is all completely free. You can go to shadowing.medschoolcoach.com, register for the program, and then you get to choose whichever specialties you're interested in to shadow. At the end, you can fill out a short quiz, and then they'll give you a certificate of completion. That way you can count these hours on your medical school application.
First, I'll just begin with kind of talking a little bit about a history of plastic surgery very briefly. I'll go into a plastic surgery 101, and these are just some basic facts about plastic surgery that I think are relevant for whatever specialty you may be going into. And then for people who are interested in plastic surgery, I'll talk about the application process at the end and just some things to be aware of as you start out getting started. All right, so first is, what is plastic surgery? So a lot of people think that plastic refers to something synthetic or something that gets implanted. But plastic actually comes from the Greek word plastikos, which means to mold or shape. And in medicine, you're going to see a lot of procedures that end in this suffix plasti, and that just refers to a procedure that reshapes or reconstructs something. Plastic surgery is actually, a very ancient specialty. It's started thousands of years ago. You have Egyptian manuscripts that talk about wound management and basic surgical procedures. One important figure that a lot of people talk about is Sushruta. He is known as the father of Indian medicine. And in 600 BC, he actually published this, I don't know if it's called publishing, sorry. In 600 BC, he described this procedure for reconstructing the nose using forehead tissue. So forehead tissue would be flipped around to cover the nose. And this is actually something that we continue to do today, or something very similar to it. In the 16th century, we have this image. This is a Talikotsi flap, and this is also a very famous image. And essentially, in this procedure, you're using tissue from the arm to reconstruct the nose. And during the process, as it heals in, you hold the arm in a splint, and then eventually, once it heals, you can divide that connection there. And all of these are, although we're not necessarily doing this procedure today, these principles still apply. We still use different parts of the body to reconstruct defects, and we, put people in external fixation while things heal. So World War I was really big for plastic surgery because you have a lot more burn injuries and also traumatic wound injuries. This is a very famous case. The patient's name is Walter Yeo, and the surgeon is a famous surgeon in plastic surgery. His name is Dr. Gillies. You lift up tissue from a donor site. So in this middle picture, it's using tissue from the person's flank. And that tissue is connected to the defect. So this patient's defect was the elbow. Walter Yeo's defect were the eyelids. And as it heals in, you keep this pedicle intact. And once it is done healing, you can divide the pedicle and then free up the tissue. In 1954, we have the first kidney transplant, and this was performed by a plastic surgeon. His name was Joseph Murray. And this is important because I think it just shows that plastic surgeons are innovators, they are pioneers in their field, and transplantation also has a key role in plastic surgery today. All right, so plastic surgery today, there are a lot of different subspecialties. Microsurgery is probably one of the biggest bread and butter aspects of plastic surgery. Microsurgery refers to using either loop magnification, so those glasses with lenses you see people wearing, or an operating microscope. And this refers to reconnecting blood vessels or nerves for a variety of different purposes. A major thing that we do is oncologic reconstruction. So after breast cancer, head and neck cancer, skin cancers, soft tissue tumors, bone tumors, anything. Limb salvage is similar, reconstructing the limb after you have either cancer or trauma or some kind of wound, like a diabetic foot wound. Lymphedema surgery, it's sometimes called super microsurgery. It's where you're reconnecting lymphatic vessels. and these can be, 0.3 millimeters, so very small. Hand and upper extremity is another subspecialty that is actually shared with orthopedic surgery. So hand surgery, it refers to surgery distal to the elbow, and you can go into hand surgery either through plastic surgery or through orthopedics. This deals with bony diseases of the hand, also, soft tissue problems, reconstructing the hand as well, amputations and reattaching fingers or hands. Pediatric hand refers to congenital pediatric hand deformities like the syndactyly shown here. Brachial plexus, so helping to repair the reconstruct the brachial plexus for injuries. Peripheral nerve surgery is also important. I put it under hand surgery, but this refers to nerves all over the body. So patients who have either nerve injuries or painful neuromas, migraines can be treated surgically. Also like things like pudendal neuralgia, decompressing nerves around the body. Aesthetic surgery, as we all know, so this is body contouring after massive weight loss, facial aesthetics, and most people are familiar with this aspect of plastic surgery. Transgender surgery, this is top surgery and bottom surgery for male to female and female to male. Craniofacial and pediatric are often lumped together. So this includes adult craniofacial trauma, but it also includes pediatric craniofacial surgery, which includes things like soft tissues, so cleft lip, but also bony deformities like craniosynostosis and other skull conditions that kids may be born with. Orthognathic surgery refers to surgery of the jaw and the mid-face. This can be for either facial aesthetics, for changing the shape of the jaw or the mid-face, or for things like opening up the airway if they were born with, issues with breathing. So I put this category here for other reconstructions. So this can include burn reconstruction, complex wound reconstruction, trauma reconstruction. And then finally, I put vascularized composite allotransplantation here. So, as we discussed on the last slide, you began with the first kidney transplant in the 50s, and now we have transplant surgery as its own specialty, and they're performing whole organ transplants. Plastic surgery today is very focused on the idea of composite allotransplantation. So this means transplanting composite tissue, so multiple tissue types together. And so this is mostly seen in face transplants, hand and upper limb transplants, abdominal wall transplants for patients who, have massive abdominal wall defects from either a tumor resection or from a military blast injury, penoscrotal transplants as well. On a daily basis, we share patients with, all these different groups. I would say at my institution, we mostly cooperate with orthopedics and neurosurgery a lot. We do a lot of limb cases with orthopedics and peripheral nerve cases. And we also do a lot of spine and skull cases with neurosurgery. I do want to clarify some of these other specialties that people often hear about. And so this is, first we have oculoplastics. So if you are interested in plastic surgery of the orbit, so this includes aesthetic eye surgery, but also things like orbital wall trauma, then oculoplastics is another field that you can go into through ophthalmology. Facial plastic surgery refers to aesthetic surgery of the face and also reconstructive facial surgery. And this is a subspecialty after otolaryngology residency. Head and neck reconstruction similarly is after ENT. And orthognathic surgery or jaw surgery, as we mentioned, is shared with oral surgery. And finally, I have cosmetic surgery listed here. And this is worth noting that this is distinct from plastic surgery. And cosmetic surgery is a specialty that you can go into even without training in a surgical residency. And just of note, it is not recognized by the American Board of Medical Specialties. So the next slide, this question is asking what is most important in plastic surgery? And most people would say something like, symmetry or aesthetic outcome. But, my job is to convince you that blood supply is the most important aspect of plastic surgery. So now we're moving into like the PRS 101 section of my talk. And I just want to clear up two terms that are thrown around a lot in plastic surgery. The first one is a graft, which most people have heard of. So like skin grafts. And the second one is a flap. And a flap is people don't really know if you're not in surgery, but this is something that we talk about on a daily basis. So a graft is when you move tissue around the body and it is avascular. So you move it without its blood supply, whereas a flap is when you move tissue with an intact blood supply. So traditionally in plastic surgery, we have this reconstructive ladder, and you're taught that you start from the bottom rung of the ladder and you slowly move up if you need more intense surgery for reconstruction. However, today, as techniques have improved and free flaps and microsurgery have become very reliable, we call it more of a reconstructive elevator now. So you pick the best option available for your patient. So starting from the bottom, we have healing by secondary intention. So this just means, doing local wound care, letting a wound heal by itself. Primary closure means suturing something closed. Negative pressure wound therapy. If you're ever rotating on a surgical service, you're going to see things like wound vacs, skin grafts, like we mentioned, dermal matrices refer to off-the-shelf skin substitutes, local flaps, distant flaps, tissue expansion, and free flaps, which I'll get into in detail. So first, beginning with grafts. Most people have heard of skin grafts. And as I mentioned, a graft is when you move tissue without its blood supply. So for a skin graft, we're shaving skin off of the thigh or the back, and we're moving it to somewhere else on the body to let it heal. As you can imagine, for something to heal, you need blood and you need nutrients. So there's this process by which skin grafts heal. And the first step is imbibition. So, the word imbibe, to drink. The first step of healing is the graft basically just sucks up nutrients from the wound bed. So whatever diffuses to the graft is how it, the nutrients it gets. Inosculation means to kiss. So inosculate. And that's when the blood vessels from the wound bed begin to, approach and touch upon the graft itself. And finally, you have neovascularization or angiogenesis, and that's when the actual graft becomes vascularized and the blood vessels connect and it's getting a blood supply from the wound bed. So most people have heard of skin grafts, but grafts are not just skin. There are a lot of different kinds of grafts. We have fascia grafts, cartilage, bone, muscle, nerve, vessel. So you can use various tissues as grafts, but again, they're being transferred without a blood supply. So now moving on to flaps. There are many kinds of flaps, and flaps really are the bread and butter of what we do on a daily basis. We have local flaps, pediculed flaps, and free flaps. And when you think about flaps, because these are tissues that are moved with a blood supply, you have to really pay attention to what the blood supply is. So if we're talking about muscle flaps, there are ways of categorizing the blood supply to these muscles. So the gluteus maximus, for example, has a co-dominant blood supply, has two major arteries supplying it. The latissimus dorsi has a major blood supply from one side and then segmental blood supply from the other. And this is very similar to the pec major as well. So, we have to know the blood supply for whatever tissue we're dealing with. For local flaps, this is based on a subdermal plexus. So the blood supply for a local flap is based on this unnamed kind of network of vessels that lies right below the skin. That's why we call it a random pattern, because it's not really a specific vessel or a specific name. It's just the subdermal plexus. And local flaps, there are a lot of different geometries you can do. So imagine, in this picture, if we have a skin cancer in this square defect right here, once you take the cancer out, you can make these other incisions and advance this tissue to cover up the defect. And so this is called an advancement flap. Similar here, if this is the defect in the pie here, you can rotate the rest of the intact skin in a rotation flap. This is a transposition flap. And in all these circumstances, the blood supply is based on the subdermal plexus immediately underneath your flap. And so if you can imagine, the leading edge of this advancement flap here, it's not getting its blood supply from the other side of the wound after you close it. It's getting it from the base of the flap over here. All the blood that's going to that tip has to travel through here. And so for things like advancement flaps, we're concerned about the tip and whether that's going to stay alive. Over here, we have something called a Z-plasty, and essentially this is for reorienting a scar. So if this dotted line here is like, a burn contracture over a joint and the patient can't bend at the joint anymore, the goal of a Z-plasty is to remove the scar, create these two triangular flaps and reorient them so that the scar is perpendicular now. So then you can bend at the joint. But again, the tips of these flaps, we're concerned about the blood supply, and the blood is coming from the random pattern based on the base of the flaps here. All right, so just to go through some, cases, these aren't real cases in that I don't have like a history or a physical exam, but they're just more to go through the thought process for some reconstruction. So a 65-year-old woman with a non-healing sternal wound after coronary artery bypass grafting using the internal mammary arteries. So after this cabbage procedure, the sternum is wired shut, and essentially this patient is having recurrent infections. It's not healing. And here we have, conservative management. So local wound care isn't working and this patient needs reconstruction. And the question is, what are some options for flap reconstruction of this patient's wound? So we want to think, first of all, is this patient a candidate for a flap? If so, can they have a free flap? Can they, tolerate being in a long microsurgery procedure, or do we need something that's more, a little more straightforward? So you can look at local options. So you have the pec major that's nearby, you have the rectus abdominis or the ab muscles, you have the omentum that's nearby. And the one I want to talk about is the pec major here. So the pec major is, the blood supply comes from the thoracoacromial artery right here on one side on the superolateral aspect. And then medially, it comes from perforating branches from the internal mammary artery, which runs under the ribs. And so, for example, in this patient, you would have to think, which vessels are already used or which ones can't we use? This patient has had a CABG before, so their internal mammary arteries actually might not be usable anymore. So instead, you can use the thoracoacromial arteries, lift up the pecs medially and advance them towards the midline. You can do it on both sides and have it cover up your sternal wound. All right, case 2 is a 70-year-old male with a large fungating mass on the scalp shown to be squamous cell carcinoma eroding down to bone. And this says reconstruction is needed after tumor resection. So the first question we have is, why can't we just skin graft? This person's missing their scalp. Why can't we just put some skin down over top of that bone? And if you go back to what we were saying about grafts, the skin graft doesn't have its own blood supply, and bone does not provide a good enough blood supply for a skin graft to take down. So you need either pericranium or periosteum or whatever underneath the skin graft to help provide a blood supply so it can heal. So in this circumstance, because the tumor goes down the bone, skin grafting is not an option. Other options we can consider, microsurgery, so using an anterolateral thigh flap, radial forearm, omentum, the latissimus. You can think about tissue expansion, so expanding the skin that's nearby, depending on the size of the defect. You can also think about off-the-shelf skin substitutes, again, depending on what you have and what this patient can tolerate. All right, so for case 3, this is a 43-year-old woman with left-sided facial palsy, so her facial nerve doesn't work anymore, after cerebellopontine angle tumor resection, and she is seeking facial reanimation. So essentially, she's had a tumor resection, and then in the process, this has damaged her facial nerve, and she's no longer able to animate the left side of her face. So for patients like this, we need to think about a few different things. First of all, what are their goals? What is the end result they want? What functions are missing? And we also want to know, how long has it been since the injury? When you have a muscle that is no longer innervated, over time it begins to atrophy, and then you can't really revive the muscle anymore. So if it hasn't been that long after the injury, you can consider a 5 to 7 transfer. Cranial nerve 5 is the trigeminal nerve, and if you recall, the trigeminal nerve does have motor components. So you can take the nerve to the masseter muscle, which is a jaw muscle, and transfer it over to the facial nerve, and that way use the masseter nerve to help power the facial nerve muscles. So that's called a 5 to 7 transfer. Another option is using a cross-face nerve graft. So you can take the sural nerve from the leg, connect it to the contralateral intact facial nerve, and cross it over the face. And this way you can have a signal from the opposite side of the face brought over to the side that's paralyzed. And if a patient has had long-standing or congenital facial palsy, then you would need to bring in a free muscle transfer. So you can bring in the gracilis muscle from the leg and use that to help power this, the facial muscle on this side, the facial muscles on this side. One thing to note is that for the 5 to 7 transfer, if you think about it, originally the masseter nerve, activates when you bite down. So for this patient, they wouldn't necessarily have a spontaneous smile. They would need to bite down in order to smile. Whereas for cross-face nerve grafts, you're using the original function to power the new function, so you can have a more spontaneous smile. All right, so just some resources. A lot of these pictures were from microsurgeon.org, and so if you are rotating on a plastic surgery service and you need to prepare for a free flap case, I really think microsurgeon.org offers a lot of information and tells you about the blood supply, the nerve supply to whatever tissues you're thinking about, different options that are available. If you ever do a sub-internship in plastic surgery, this is the book that you definitely should get. It's Essentials of Plastic Surgery. It's a really thick book, but it covers a lot about the various subspecialties. If you're on orthopedics or plastic surgery and you have hand consults or something that comes in, Ortho Bullets is really useful. You can just search distal phalangeal fracture, and it'll tell you, things to look out for on exam, different kinds of management depending on the situation. So this is a great resource, for your rotations as well. And then for craniofacial trauma, the AO has a website for, also you can just pick, where the issue is, and it'll take you through different things to think about. So why plastic surgery? So first of all, the field, there's a lot of innovation. The field is constantly changing. Things like microsurgery, those are all relatively new. And we are constantly trying to develop new ways to reconstruct these kinds of wounds. So I think there's a lot of innovation. There's a lot of research going into things like biomedical engineering, like I mentioned earlier, different types of biomaterials that we can use for reconstruction as well. I think that plastic surgery has a lot of pioneering new options for patients. We don't try to just come up with one solution. We try to offer options for patients, whether this is gender affirmation surgery or whether this is rehabilitation for amputees. We try to come up with more than one option that patients can have. Every procedure requires thinking outside the box. So you come in with your plan, but you always have to think about backups. Think about what other tissues are available. What are ways that you can salvage, what's going on if something goes wrong. So it really requires a lot of creative thinking. Every piece of anatomy is covered in plastic surgery, so you really have to know head to toe, all the different tissue types, the different blood supply, nerve supply to things. And there's a lot of different types of thinking. So for example, for breast cases or for body contouring, you really have to, there's a lot of 3D, visualization of what's going on. For hand cases, you have to think more, biomechanically, about, it's more of the engineering side of your brain. If you're doing tendon transfers, you have to think about how much tension to put the tendons under to have, the optimal function. And also things like peripheral nerve surgery. I think nerve is really cool. And it's kind of like neurology because you're using your physical exam to pinpoint, well, where along the nerve is the lesion, because is sensory function affected or is motor function affected? And you use your physical exam to help you diagnose what's going on. And finally, there are diverse and flexible career options. You can get fellowship in one subspecialty, but many people, they're not limited to just operating in that specialty. And your career can change as you go along, depending on your interests. So now just to talk about the application process, there are two main ways to go into plastic surgery. One is the integrated path. So this is residency directly after medical school in plastic surgery. And the other is the independent path. So for the integrated, you finish medical school and then you match directly into plastic surgery. And this is usually a 6 to 7 year program. Most are 6 years. There's a handful that are 7 years. Afterwards, you may or may not, decide on fellowship, and fellowship is usually 1 year. The other option is to go into residency in another surgical specialty. So general surgery, ENT, urology, or whatever. And then you finish, or after that, you do 3 years in an independent plastic surgery residency. And then you can do fellowship if you want. So currently there are 82 integrated programs and 44 independent programs. People worry that there might be fewer and fewer independent programs. And while some places might cut down on their independent programs, I don't think they'll go away forever. So there always will be that option for people who finish general surgery to go into plastic surgery. So what's important for your application? I would say it's your commitment to the field. For your application, one of the most important things would probably be recommendation letters. And plastic surgery also has something called an ACAPS form. And essentially your rec letter writers have to fill out this form that asks, it ranks you on 10 different qualities or some number of different qualities, and also asks for how they would rank you out of plastic surgery applicants. So this ACAPS form is something that's unique to plastic surgery, and your letter writers are supposed to fill it out. Research is pretty important for plastic surgery, as I mentioned, especially in the field of plastic surgery, but it doesn't have to be. They just want to see that you are, academically oriented and have done some research. Sub-internships traditionally have been very important. And so sub-internships are when you rotate at a different institution during your 4th year of medical school. And this is a good chance for another institution to get to know who you are and see how you perform in a clinical setting. And if you do well, then your sub-internships are, some of your best chances of matching, because they trust you, they know you, they have an idea of what they're getting if they match you. And then scores, your resume, your personal statement. And finally, your MSPE letter. So this is a letter that your school writes for you. It is not as important because it doesn't actually say much about plastic surgery. I think your rec letters are probably more important than your MSPE letter. So things that you can do now, I would say find a mentor, especially one in plastic surgery, because they can tell you, what steps to take. Get involved with your plastic surgeons. If your school has plastic surgeons, then definitely start going to any research or education events, start shadowing, ask them if they have research opportunities available. If your school doesn't have any plastic surgeons or there's no plastic surgery program at your institution, then you can consider looking at nearby institutions in your city, or if you have a summer break, then going somewhere that does have a plastic surgery group that you can rotate with or do a summer research project with. And finally, conferences are important. So this year, everything was virtual and they've been less of an opportunity to network, but typically conferences are a great place to network, to meet program directors and meet other applicants from other schools. The American Society of Plastic Surgeons, the name of their conference is PSTM, and they have a medical student day where they have program directors come talk to you and they just talk about the application process, and it's super helpful.